afternoon to all. I welcome you to the first of the webinar series that has been designed for the pathologists and hematopathologists. This is Myeloproliferative Neoplasms, and this is scheduled under the aegis of DSH and organized by Sir Ganga Ram Hospital. I welcome all the interested participants, and there has been an overwhelming interest of more than 500 participants for these webinars. Hope you are all doing well. And I now, before asking our Dr. Jyoti to introduce our esteemed speakers, two important messages. Kindly save this link. This link is going to be the same for the upcoming webinars. And also the question answers will be dealt by the end of both the talks. Now I welcome Dr. Jyoti Kotwal, our Program Director, to kindly introduce our esteemed speakers. Ma'am is the Head of Department and Professor at Sir Ganga Ram Hospital. Dr. Jyoti, ma'am.
Thank you, Dr. Sabina. A very good afternoon to all the participants and the faculty. We have taken up the topic of myeloproliferative neoplasms because the differential diagnosis of the various subtypes is a diagnostic challenge with specific morphological features and molecular studies. Clues to the subtypes come even from the CBC values, and we hope to provide you with an academic feast in the coming 4 sessions. We have 2 speakers today, Dr. Tejinder Singh and Dr. Renu Saxena, and both the professors need no introduction to this August gathering. They are both doyens in the field of hematology. The first speaker, Dr. Tejinder Singh, has been the professor and head of pathology at Maulana Azad Medical College and is now a senior consultant heading hematology at the Oncquest Lab. And he is an expert in bone marrow morphology. Dr. Renu Saxena will be speaking to you on the molecular aspects, and she has been the professor and head of hematology at All India Institute of Medical Sciences, and now she is the Director of Laboratory Services at the Medanta Medicity Hospital. I will not stand between you all and the August faculty, so I hand over the arena to Dr. Tejinder Singh for his talk. Thank you, sir.
Thank you, Dr. Jyoti. And it is always a pleasure to be associated with DSH. I'll share the screen. Am I audible?
Yes, sir.
Yes, sir, you're audible, sir.
And
so could you put it on slideshow? Yeah.
Yes. I'm sharing the screen now. Is it okay?
Yes, sir. Please go ahead. Thank you.
Okay. Thank you, Dr. Jyoti. And at the outset, I would like to express my gratitude to Dr. Jyoti Kotwal and her team. And it is always a pleasure to be associated with DSH. And it is long time since we had started DSH, and it is indeed a pleasure to see Dr. Jyoti Kotwal now taking the flag onwards. Now, myeloproliferative neoplasms is that the cells which lead to the proliferation are in the hematopoietic stem cell compartment. Now, this is what it is. Stem cell goes on to myeloid stem cell, and here we find that there is an uncontrolled proliferation of the red cells resulting in polycythemia, to platelets resulting in ET, to white cells, it results in chronic myeloid leukemia. So this group of disorders has effective hemopoietic proliferation. Now, fibrosis is common in all of them. In some in initial stages, in others in late stages. All of them are associated with hepatosplenomegaly of a variable degree, and there's a clonal marrow hyperplasia without much of dysplasia. Now, WHO classification of 2016 classified into 2 main groups. One is BCR-ABL positive, that is CML, which we are not discussing today. And then we have a major group of BCR-ABL negative, that is polycythemia vera, ET, and primary myelofibrosis. Now, what is essential for a myeloproliferative disorder is the driver mutation. Each myeloproliferative neoplasm is associated with one driver mutation, which may be CALR, JAK2, MPL in BCR-ABL negative. And see the frequency in these three major diseases. In polycythemia, it is mainly the JAK2. And then we find in ET, it is JAK2 is the main, followed by CALR and then non-mutated. And then we have PMF, where we find JAK2, CALR, MPL. And then we have triple negative also, where we find that these ones are not present, but some minor other mutations are present. Now, as far as JAK2 is concerned, what we find is that JAK2 is a mutation which can give rise to either ET, it can give rise to polycythemia vera, and it can also give rise to primary myelofibrosis. Now, why does it happen? Is it the allele burden, which is low, then ET? If it is intermediate, it is polycythemia vera, and if it is very high, then it becomes a case of myelofibrosis. Now, the details Dr. Renu Saxena will be providing us. Now, what has happened in this 2016-17 classification is that bone marrow morphology has been given a lot of importance. There is accurate reticulin fibril grading which has come, and there is standardization of the bone marrow morphology parameters. Now, these have to be correlated with the clinical findings, the molecular markers, and then we diagnose them what the disease is. Now, before I go on to a disease entity, I would briefly discuss about the megakaryopoiesis, because the megakaryoblast are the large cells which are present in the bone marrow. They go on to enlarging in size, and the granularity of the cytoplasm appears, which become promegakaryocytes, and then these become multilobated, cytoplasm becomes granular, and then the platelets are shed off from these megakaryocytes. Now, this is what happens by endomitotic divisions of the megakaryocytes. The granularity keeps on increasing, and they keep on forming the platelets from there. And then this is under the control of thrombopoietin, GATA1, FOG1, and FLY1. And in some of the megakaryocytes, the proliferation goes on to 8N and even 16N. And that is what you find, the budding of the platelets takes place from the surface of the megakaryocytes. And then the size. There are different terms which I'll be using today, like normal megakaryocytes, dwarf megakaryocytes, giant megakaryocytes, dysplastic megakaryocytes, and the megakaryocytes with bulbous or cloud-like nuclei. Now, this is a case of ITP, where we find by and large the megakaryocytes are of normal morphology. Now, these are the normal megakaryocytes on the smear, where you find multilobated nuclei are present. The size is normal. Similarly, on a bone marrow trephine biopsy, you find the megakaryocytes with multilobated nuclei. Size is within normal limits. And then we have micromegakaryocytes, which are small. They have a lobated or a non-lobated nuclei in majority of the cases, or it may be bilobe. Few of the megakaryocytes may be even binucleated, and this is a typical feature of MDS. Micromegakaryocyte presence is indicative of MDS changes in that particular case. And then we have giant megakaryocytes, where the megakaryocytes are huge. There is hyperlobation and staghorn type of nuclei are seen. And then you find here, you can see that these are large megakaryocytes, what we label them as giant megakaryocytes, and these are seen in ET. Then we have dwarf megakaryocytes, where the megakaryocytes are smaller. The size is small, the nucleus is hypolobated. Same is true on the bone marrow trephine biopsy, and these are mainly seen in cases of CML and also in some cases of PMF. And then we go on to distribution of the megakaryocytes. What is the distribution? On bone marrow biopsy, clusters, paratrabecular, and megakaryocytes lining the sinusoids. But first of all, what is the normal distribution of megakaryocytes? Now, this is a bone marrow biopsy. What we find is that the megakaryocytes are present in the central part of the marrow. They are nowhere near the bony trabeculae. So this is the normal distribution of megakaryocytes. And then we find that megakaryocytes are in clusters. You find 5 of them. And here you find 20 of the megakaryocytes, which are very, very close to each other. Here we find they're close to each other, but some marrow cells are coming in between. These we label them as loose clusters of megakaryocytes. On the other hand, in here we find they're so closely packed that there are no cells in between. These are called dense clusters of megakaryocyte, or we call them as tight clusters of megakaryocytes. Sometimes we find that the megakaryocytes are lining the sinusoids. This is a sinusoid, and you find the megakaryocytes are lining it. This is the bony trabecula. This is the marrow. And what we find, megakaryocytes have come to lie in the paratrabecular location. This is what we call as change in location of the megakaryocyte, or we call as heterotopia. Megakaryocytes should have been in the central part of the marrow, but they have come in the paratrabecular location. Similarly here, you find that they are not only proliferating, they are dwarf megakaryocytes, small hypolobated nuclei, and all of them are present in the paratrabecular location. Now, this is a feature of primary myelofibrosis. And this is a normal morphology, where the megakaryocytes are discrete and in the central part of the marrow. Another thing this WHO classification has given us is the reticulin grading, so that we have a standard reticulin grading, and this has been divided into 4: MF0, MF1, MF2, MF3. Now this is MF0, where we find that there are thin linear reticulin fibrils with no intersections, as in this case. And then we have MF1, where we find that there are many small intersections of the thin fibrils of the reticulin. And then we have MF2, where we find that there are extensive intersections to these fibrils of the reticulin. And finally, we have MF3, where we find that there are dense, thick fibrils. Not only that, there are multiple extensive intersections. And then finally, these reticulin fibrils go on to collagen fibrosis, and sometimes it may even go on to osteosclerosis. Now, this is what happens, grade 3 reticulin, and you are finding that there is a collagen fibrosis. Besson's trichrome stain, the blue color, brings out that there is collagen fibrosis. And then we find here the bony trabeculae have become thickened. The marrow has undergone fibrosis. Now, this is what we label as osteomyelosclerosis. Now, we go on to a case study. A 58-year-old male complained of headache, no other complaint, no liver, no spleen, congested conjunctiva, raised hemoglobin of 17, TLC is high, platelets are 8.9, clinical diagnosis, MPN, query ET because the platelets were high, query polycythemia because 17 grams. But then we know also that PMF can also present with a similar picture in initial stages. However, the JAK2 turned out to be positive. So we have, again, we know it is MPN, but we don't know what is the cause. So what can clinch the diagnosis is the bone marrow. Bone marrow was hypercellular. Not only that, there was a trilinear hyperplasia, and the iron was grade 0. So 80% cellularity, panmyelosis, picture is suggestive of polycythemia vera. Though we have JAK2, we have all the parameters, but the diagnosis could be clinched only on the bone marrow refined biopsy. So that is why the morphology of myeloproliferative neoplasms has assumed a lot of importance in making a diagnosis of various MPNs. Now, this is a review article by Barboe along with Professor Orazi and Professor Teferi, where they have given the summary and in-depth discussion on the 2016 WHO classification and how it has helped in classifying the various myeloproliferative neoplasms. Now I'll take one by one, starting with ET, where we know that the platelet count should be more than 4.5 lakhs. Bone marrow biopsy. Earlier, bone marrow biopsy was not given as much importance, but now we know that WHO has given an importance to both bone marrow aspirate and bone marrow biopsy. So what we find here, there is mainly a proliferation of the megakaryocytic lineage. That means the myeloid and the erythroid series are by and large normal. And there is mature megakaryocytes, which are enlarged, giant megakaryocytes, and hyperlobulated nuclei. And rest of the things are normal. And of course, the other myeloproliferative have to be ruled out. Then there should be a driver mutation, and that driver mutation could be JAK2, CALR, or MPL mutation. And of course, a clonal marker in case these are absent. But what we have to keep in mind is the reactive thrombocytosis is much more common than a clonal thrombocytosis. Though this clonal thrombocytosis can occur not only in ET, but we also come across it in PB, PMF, CML, and even in MDS, 5q deletion cases. And then we have atypical myeloproliferative disorders. So reactive thrombocytosis can occur whenever there is a chronic inflammation, tissue damage, post-operative, giant cell arteritis, various malignancies, hemolytic anemias, post-splenectomy, and iron deficiency anemia. This could be a cause of thrombocytosis in certain cases. So what are the criteria for ET as per WHO? Number one, peripheral smear, red cells are by and large normal, WBCs are normal, platelets are increased. As you can see, tremendous increase in platelets. And what we find is anisocytosis. Some of the platelets are large, some of the platelets are normal size, and even few micro platelets can be seen. But WHO has given the importance of megakaryocytes. On an aspirate, we may or we may not find loose clusters of megakaryocytes. However, what we find is the platelet clumps are seen all over the bone marrow aspirate smears, and one we come across are the giant megakaryocytes. Now, these are the giant megakaryocytes in a case of ET. Here also you find these loose clusters of megakaryocytes are present, and these are hyperlobated, which we can see on bone marrow trephine biopsy. One of the characteristic feature of ET is a scanner view of the bone marrow trephine biopsy. What we find is fat is more than cells. Now, this is one myeloproliferative disorder in which the marrow fat remains nearly normal, and the marrow is not hypercellular. It may be mildly hypercellular, but it is unlike polycythemia, unlike it is CML, and it is totally unlike PMF early stage. So normal cellularity, clusters of megakaryocytes is an indication that we're dealing with a case of ET. And what we find is the megakaryocytes with hyperlobulated nuclei. That is what on bone marrow aspirate, hyperlobulated giant megakaryocytes is the typical feature. And these are the loose clusters of megakaryocytes, which show staghorn type of nuclei. This is one megakaryocyte which is showing emperiopoiesis. And then we go on to polycythemia vera. It is the commonest myeloproliferative neoplasms, two phases. But now we come across one is overt polycythemic phase and second is post-polycythemic myelofibrosis phase. Now this is one disease where the molecular alteration is only JAK2, which may be exon 14 or which may be exon 12. By and large, CALR and MPL or triple negative are uncommon. The moment we make a peripheral smear, we come to know that hemoglobin is very, very high, but we don't know whether it is a polycythemia vera or it is a case of reactive erythrocytosis. This is a normal smear. NAP score is high, as you can see, 3 and 4. And then iron stores are nil. As the red cells or the normoblasts keep on proliferating, they keep on utilizing iron and the iron stores become nil in these cases. Platelet count is little bit high, usually may go up to 9 lakhs. Blood volume is increased, ESR is low, NAP score is high. The major criteria, now it has been reduced. Now the hemoglobin in men should be more than 16.5 and women it should be more than 16 grams with 49 and 48 hematocrit. What is the typical feature is hypercellularity for age. There is panmyelosis, trilineage growth. That means myeloid, erythroid, and megakaryocytic. Though this is a disease of red cells, but what we find is panmyelosis, which is, and second is the megakaryocytic proliferation shows us pleomorphism. mild degree of pleomorphism we will come across, and then JAK2 mutation, and of course subnormal EPO levels. This is the bone marrow aspirate picture. Hypercellular marrow, you don't find much of fat. Second, you find megakaryocytic proliferation, and then you find erythroid proliferation, and then you also come across myeloid proliferation. And then you find the megakaryocytes are of different sizes. So mild pleomorphism of the megakaryocytes, especially size, and trilineage hyperplasia. This is the bone marrow biopsy. Hypercellular, you find around about 90-95% cellularity. Erythroid hyperplasia, as you can see, colonies of erythroid precursors, myeloid hyperplasia, and of course the megakaryocytic hyperplasia, as you can see. And there is a variation in the size of the megakaryocytes. In the overt polycythemic phase, we don't come across much increase in reticulin. So reticulin is usually grade 0 to 1. And that is a hyper view. You can see the erythroid proliferation, clusters of these normoblasts, the dark ones, and then you find the myeloid proliferation, megakaryocytic proliferation, and all megakaryocytes are different from each other. That is what WHO label as pleomorphic megakaryocytes in a case of polycythemia vera. Now, what happens to these cases? Over a period of time, the marrow fibrosis starts. Gradually, the marrow fibrosis keeps on increasing. At the same time, the splenic size keeps on increasing, so there is a splenomegaly. So later on, it can lead to post-polycythemic marrow fibrosis, and then some of these cases may go on to post-polycythemic myelofibrosis with accelerated phase, and which may then go on to even a blastic transformation, and that is a terminal stage of polycythemia vera. Now, this is the post-polycythemic vera myelofibrosis. When this happens, we come across, there are teardrop cells which become present in the peripheral smear. The hemoglobin falls, the red cell count falls, and what we find in the bone marrow, there is a tremendous amount of fibrosis. Usually, initially it is MF1, it may go on to even MF2. Then the megakaryocytic proliferation is much more. There is change in topography of megakaryocytes which come to lie in the paratrabecular location like in PMN. Now this is what happens, but the indication that it was post-polycythemic myelofibrosis is given by the presence of erythroid hyperplasia. That still persists though the patient has gone on to myelofibrosis. And this is the reticulin stain. You can see the increased reticulin, grade 2, MF2. That is the type of reticulin we come across in these cases. Then we go on to primary myelofibrosis. Now there are 5 stages. First is prefibrotic, PMF, overt or the fibrotic phase. Then we have the osteomyelosclerosis, which may go on to accelerated phase, and finally there could be a blastic phase. Now JAK2 mutation is present in about 60%, CALR is present in about 30%, then we have triple negative about 5 to 7%, and about 5 to 7% cases have MPN mutation. Now since WHO has classified and they have given separate criteria for prefibrotic, for fibrotic, and for osteomyelosclerosis. Now what happens in prefibrotic? Now prefibrotic, as the name indicates, is before the fibrosis ensues. So what is there? It is a very, very hypercellular marrow with a tremendous megakaryocytic proliferation, not only proliferation, and atypia. Now this is one disease where atypia is maximum in the myeloproliferative neoplasm. In others, we don't come across much of atypia. This is the only disease where atypia is rampant throughout the bone marrow, but there is no reticulin fibrosis in the prefibrotic. What we are talking of is prefibrotic without reticulin fibrosis, increased marrow cellularity, and then we have one of the driver mutation, JAK2, CALR, or MPN mutation. And the cases which are triple negative, it may be ESXL1, EZH2, TET2, IDH1, or IDH2 in these cases. So what do we find on morphology? First thing is there is a tremendous granulocytic proliferation, rather the erythroid precursors are diminished. Second thing, there is a tremendous megakaryocytic proliferation, and then this is one disease in which there are tight clusters of megakaryocytes. They're just sticking to each other. You can see them even on bone marrow aspirate. This is the bone marrow refined biopsy. In a case of pre-fibrotic phase, what we find is tremendous cellularity, anything from 90 to 95%. And then you find there is a megakaryocytic proliferation, and second, granulocytic proliferation. The erythroid proliferation does not take place in this. Second thing is that there is change in topography of the megakaryocyte. They have come to lie in the paratrabecular area. You find proliferating megakaryocytes, all of them in the paratrabecular area. So change in topography of the megakaryocyte, along with we are finding the granulocytic proliferation. Then we find megakaryocytes with pleomorphism, atypia. Here you find bulbous nuclei or cloud-like nuclei. These nuclear chromatin is open. You find some stippling, and these are cloud-like nuclei, which is very typical of a hypercellular phase of PMF. And then there is a granulocytic proliferation, and then these are forming tight clusters of megakaryocytes. No cells come in between them. Again, bulbous nuclei, cloud-like nuclei. Then you find this clustering is present, and these are the features which are typical of PMF. Here you find a very dense cluster of megakaryocytes with pleomorphism, bulbous nuclei, and the tremendous granulocytic proliferation. Now, this is unlike you have seen in polycythemia vera, or we have seen a normal marrow in cases of ET. Then we go on to the fibrotic phase. Now, what happens in fibrotic phase? In a peripheral smear, you find large number of teardrop cells, and then there is a leukoerythroblastic blood picture. Here you can see a late normoblast. So there is a megakaryocytic proliferation persists, atypia persists, but there is now reticulin and or collagen fibrosis. But there must be presence of a driver mutation. That is one of these, JAK2, CALR, or MPN. Now, this is what happens in a fibrotic phase. You find the sinusoids are dilated. Number two, you find there is a megakaryocytic proliferation all around. There is clustering of the megakaryocytes. There are bare nuclei of the megakaryocytes. And then you find here that the reticulin has increased. You find grade 2 to grade 3 reticulin is seen in primary myelofibrosis. You find hyper dilated sinusoids, granulocytic proliferation, clustering of megakaryocytes, bare nuclei of the megakaryocyte, and atypia of the megakaryocytes. Here you find that megakaryocytic proliferation is more than even granulocytic proliferation, and there is streaming of the cells, and you find there is associated marrow fibrosis. Here you find the dilated sinusoids are lined by these megakaryocytes. Some of them are atypical with bulbous nuclei. Here there is change in topography. The megakaryocytes are next to the trabecula. So they are shifting. Not only they are present in the paratrabecular area, but in the central parts of the marrow as well. So reticulin is increased. Collagenization occurs, what we now call as grade 3 myelofibrosis. And then agnogenic myeloid metaplasia occurs in lymph nodes, spleen, and liver. Here we find liver showing us extramedullary hematopoiesis. This you find in the spleen, and this is in the lymph node. The megakaryocytes and the normoblast present indicate that there is extramedullary hematopoiesis in spleen, lymph node, as well as in the liver. Now, normally what happens is the function of the osteoclast is to cause resorption of the bone. But in myelofibrosis, under the influence of one of these mutations, JAK2 or CALR, what we find is the number of nuclei has decreased, the fusion capacity has decreased, their resorptive function decreased. Rather, what we find is the osteosclerosis occurs. That is why we find that some of these cases, they have already undergone myelofibrosis, but now the bony trabeculae get thickened. There is a new bone formation, and you find new bone formation leads to narrowing of the cavity. And in this condition, what we find is that the bone constitutes more than 50% of the bone biopsy. So that means the marrow spaces get narrowed. This is a new bone formation which occurs on the existing bony trabeculae as well. And then this gives on to a what we call as accelerated phase. That is, now the blast cells start appearing in the fibrotic marrow, and sometimes it may be a type of blast crisis. Sometimes, most often, it is a milder type of blast crisis, and that is what we find. So whenever we do a bone marrow aspirate for the type of blast crisis, we may not get a good bone marrow aspirate because there is tremendous fibrosis. So it is an immunohistochemistry on bone marrow biopsies to clinch whether it is myeloid or it is a megakaryoblast type of blast crisis. So in myeloproliferative neoplasms, what we have to do is BCR, ABL, CML. Otherwise, we have to go through JAK2, followed by CALR, and then followed by MPL. So the take-home message is that now driver mutation is to be, in any case, it has to be proved. Second thing is the morphology, because JAK2 could be positive in all the three. So therefore, it is the morphology which will give us the diagnosis, whether we are dealing with PV, whether we are dealing with ET, or we are dealing with a case of primary myelofibrosis. Now, the clinical data is to be correlated with the morphology. Driver mutations will confirm the clonal nature of the disease. So who will make the final diagnosis? Final diagnosis is to be given by us, by the pathologist, after study not only of the bone marrow aspirate, but of the bone marrow biopsy as well. Thank you so much.
Thank you, sir. We'll have questions at the end of both the sessions. So now I invite Dr. Renu Saxena to give her talk on the molecular aspects of Philadelphia negative MPNs.
Thank you very much, Dr. Jyoti. I'll just share my slides. So at the outset, I'd like to thank Dr. Jyoti and her team for giving me this opportunity to speak there. I think it's a very great initiative, and I do think we should continue this if people like it. So without going into very much of further talks, I would like to straight away start with the follow-up lecture, which is on molecular diagnosis of Philadelphia negative MPNs. So already Dr. Singh has laid the background for molecular genetics, and what I'm going to talk about in the next few slides are how we use it and what are the techniques by which we can assess these. So, the molecular genetics for MPNs started way back in 2000, early 2000s, 2005, 2006, and it was first incorporated in the 2008 WHO classification for myeloid neoplasms. And as pointed out earlier, MPNs were classified into two subgroups, classic and non-classic. Amongst the classic, what we are going to be dealing today are the PV, ET, and PMF, which we already know, as by Dr. Singh, that JAK and MPL were the ones which were initially detected and have been implicated in pathogenesis of these three non-CML disorders. And then there is a huge chunk of non-classic MPNs, of which systemic mastocytosis also has a very specific mutation which we need to be looking at. So if we go into the history, the earliest to be detected was JAK2 mutation, first described in PVRA as early as 2005. In 2006, the MPL mutation was described in about 4 to 5% of PMF patients. And therefore, in 2008 classification, we had both these in the classification of MPL. In 2013, a new mutation of CALR was found to have a role in PMF, And in 2016 classification, all these three have been included as the major criteria for diagnosis of MPD. So what does this mean actually? As was already pointed out, and something what we see very often when we are doing day-to-day morphology is you need to have differentiation of P vera from secondary or relative polycythemia, which is actually in terms of numbers probably more common than P vera. Similarly, you need to differentiate essential thrombocythemia from the huge number of list of reactive thrombocytosis which Dr. T. Singh showed. Similarly, a huge number of causes of secondary myelofibrosis are described. We need to pick up primary. So the detection of these underlying mutations, therefore, has a role in clinching diagnosis of clonal disorders from reactive or non-clonal condition. However, these do not help in differentiation amongst the different types of myeloproliferative neoplasms where we need to fall back on morphology. Also, this does not affect or predict AML transformation. So therefore, it has a very specific role in only picking up clonal MPDs. So we'll talk a little bit about each of these mutations, how we go about doing it. So JAK mutation is a single amino acid substitution from valine to phenylalanine at position 617 in the JAK2 domain. And as already pointed out, this is seen in a number of myeloproliferative disorders, most commonly P vera. So therefore, you have about 5% of P vera patients who may still be negative for JAK mutations. And it is here that you can look at mutations in the exon 12 of JAK, and this is seen in 2 to 5% of polycythemia vera patients. This targets the K539 amino acid residues, and this actually presents as deletions and insertions, which may be picked up by either sequencing or NGS. JAK mutation, there are several techniques to pick it up, depending on what facilities you have. At AIMS, we were using ARMS PCR, and we could differentiate between homozygous and heterozygous mutation. As you can see here, you have the homozygous ones where you can actually see two bands here, unlike the heterozygous ones where you are seeing different bands. We are at Medanta now. We are doing the Quant Studio real-time PCR equipment, and this is how we do. So we put up a negative control, which as you can see comes out like a flat line. And always, these are all the controls that we always have to put up with all the cases. So we also always put up a wild type, which again comes out like a lower CT value, so to say. It comes out lower height. So, and a mutant control, which gives a high rise. So what we look at here is the x-axis, which gives the copy numbers, and the y-axis, which gives the CT or the cycle threshold value. What we have to look at is what is the value at which there is a rise occurring in this. And this normally occurs between 20 to 30 CT values. Now this is from a case, and if you can see here, you can see this is a patient, and as you can see here, this is the JAK mutant, which is rising at the same time between 20 and 30, and this is a case which is positive for JAK. On the other hand, the control here is a straight line, hasn't risen up at all, and only wild type is present. This is called as a mutant type. So we looked at JAK mutations in our own population at AIMS. We did a study of about 75 MPD patients, and we found in P vera, our number was as much as 82% had JAK mutation. In idiopathic primary myelofibrosis, we had about 52% positivity. In ET, we had a positivity of 70%. Moreover, we found patients who had these mutations had a significantly higher mean WBC, higher hemoglobin, and higher platelet count compared to those who were wild type JAK mutated. When you look at the prevalence of JAK mutation in India compared to elsewhere, you find that JAK mutation is not as high as 95%, but still the highest number. ET is slightly on the higher side. MF is almost the same percentage, about 50-60. So how does JAK mutation lead to myeloproliferative disorder? If you know what is the role of JAK mutation in hematopoiesis, what happens in mutation will follow. So normally what does JAK do? It is actually activated by the ligands, and this actually causes activation of the STAT proteins, and therefore it enhances the terminal differentiation of erythroid, megakaryocyte and granulocyte precursors into mature blood cells. Therefore, it follows that anything that is going to stimulate this STAT protein further or make it independent of activation by ligands is going to cause unlimited differentiation of all these three Cs. That is exactly what happens with JAK mutation. What it does is it makes it independent of ligand. And once this independence is achieved, there is accentuated differentiation of erythroid, megakaryocytic and other series, leading to either erythrocytosis, thrombocytosis and leukocytosis. That is the classic myeloproliferative disorder to see. So Dr. Singh also talked something about JAK allele burden. And of late it is assuming importance. We do know that it is higher in P vera, not as high maybe in myeloproliferative disorders. Nevertheless, there is a role that has been defined in myelofibrosis, and that is what is the role of allele burden in P vera and MF. So we looked at P vera cases and we found high allele burden was associated with higher thrombosis. When we look at the MPN mutation, that is the second mutation which was found, and this, well, how does this act? This is actually a thrombopoietin receptor gene, and what this does is it is a gain of function mutation found in almost 9% of PMF negative JAK negative cases, and in ET it is found in about 1 to 5% of JAK negative cases. What it does is it stimulates the action of JAK-STAT. So what it does it is associated with more proliferation of the various three series of cells. It has been associated with more severe anemia, more thrombocytosis and more leukocytosis, but it is not really associated in polycythemia. We in our studies did not find any case positive to be MPN. Then we come to the third picked up mutation, that is the CALR mutation. This is a gene which encodes the endoplasmic reticulum associated chaperone cells, and this mutation is seen in 35% of ET and 25% of PMF with unmutated JAK and MPN mutations. What does this do? This causes overactivation of JAK-STAT signaling, which, as I told you before, leads to unbridled proliferation of all three series of cells. And then there is derangement of cellular functions by the mutated proteins. Now we have two types of CALR mutations. You have type 1 and you have type 2. Type 1 is more often associated with PMF and type 2 is preferentially associated with ET. And these two types constitute more than 80% of all CALR variants. So what are the methods of detection of CALR mutation? We used to do it earlier by Sanger sequencing. Today we can also do it by RT-PCR. You can also do it by NGS, or we had a thesis by one of our students where we could even demonstrate it by IHC. So it depends whatever equipment you have. So as I said, we had earlier done a study on CALR mutations using Sanger sequencing. And what we found, we did this in PMF cases, and we found 9 out of the 35 patients had CALR mutations, and it was mainly type 1 mutation. As I said, in PMF, you don't get type 2 mutation. We didn't find any type 2 mutation. However, we did find one novel mutation for this. Now we are doing at Medanta, we are doing with our qPCR, and this is how you see. You always put an internal control, which comes as a low rise or a flat line, and if there is presence of CALR mutation, you see a rise here, which comes between 20 to 30 CT values. And this, as you can see, is negative. There is a flat line. So one can use whatever method is available to you, and you can pick up. And we found, here also we found it is the CALR1 type which is positive. We have not found CALR2 positive. When we look at primary myelofibrosis, we did this at AIMS, we found 56% were JAK positive and CALR positivity was seen in 25%. No MPL mutation was seen. So we had about 30% who were triple negative. What do we mean by triple negative? Triple negative means those who are negative for all these three mutations. We don't know what is the significance of these, clinical significance of these as of now, but what we do know is how we should proceed to confirm clonality in these. So this is the data that we got in Medanta. We had again JAK mutation found in PV of 75%, 72% in ET, and about 50% in MF. CALR we found in as much as 18% of ET, and we had a similar percentage at AIMS. Coming to triple negative MPNs, these patients, you need to look for additional mutations. This is the whole list of mutations that you can look at, which give an idea of clonality. And these, in today's date, we can do by NGS. So we at Medanta, we have iron torrent NGS system, and there we are going to be starting it next week. We plan to use the Oncomine panel, and therefore we need to be looking at all these mutations. If you find them present, that is an indication of clonality. Now, coming on to the molecular genetics of non-classical CMPDs. So what are these? So we have chronic neutrophilic leukemias, we have chronic eosinophilic leukemias, NOS, that is not otherwise specified, systemic mastocytosis, and so we need to look at molecular genetics to confirm or exclude these. So what do we do in neutrophilic leukemia? We exclude CML. So therefore, you run a BCR-ABL, and you, particularly if you find P230 transcript, you might think this is a chronic neutrophilic variant of CML. And of course, now newer mutations are also coming. Chronic eosinophilic leukemia, you have to exclude hypereosinophilic syndrome by doing PGFR alpha rearrangements, PGFR beta rearrangements, and FGFR rearrangements. For mastocytosis, you have to look at c-KIT mutation, which we are doing by real-time PCR. When all mutations, everything comes negative and you have not been able to classify in any of these, you dump it in CMPD unclassified. So in the next few minutes, I'll take you across how molecular genetics helps in picking up non-classical MPDs. So this is the way on our real-time PCR is shown in our BCR-ABL RQ-PCR. This is, you get a flat line, it's negative for BCR, you get a rise about at 20 CT, it's a positive for BCR. And you run all the three variants, P230, P210, and P190, all three flat means absence of all these. So you can do PDGFR alpha rearrangements either by real-time PCR or by FISH. We are doing it with FISH at Medanta, and just to briefly give you how FISH helps us, this is a schematic diagram, and what we use is a tricolor deletion probe in this. So normally you get a picture like this, but when there is presence of this rearrangement, the red goes away, and therefore you get it deleted. So this is an actual picture from a case, and here you can see red is present in all, so this is negative for PDGFR arrangement, and this is what you need to have CEL-NOS. We use a different kind of probe for PDGFR beta rearrangement, so we use a break-apart probe. So this is a schematic diagram. This is what a probe looks like. A positive one, it's a fused one, but if there is presence of rearrangement, it breaks into two separate signals. That's a schematic diagram, but this is the actual picture where you can see there is no break-apart probe, no break-apart present, so this is negative for PDGFR beta. So we also do FGFR1 rearrangements. Again, here we use the break-apart probe, and as you can see, there is all fused signals, so this is negative for FGFR. And then I will take you along to the role of molecular genetics and cytogenetics in risk stratification, which is particularly known for myelofibrosis. So we are all familiar with the IPSS risk stratification and the DIP-DIPS risk stratification, but newer risk stratification classifications which have emerged are the MIPSS 17, which incorporates the mutations and the clinical profile, MIP 70 version 2, which in addition to mutations and clinical, it also takes into account karyotyping, and the GIPS, or the genetically inspired prognostic scoring system, which does not handle the clinical at all, is only based on mutations and karyotype. So we know that apart from diagnosis, mutations and karyotyping are becoming very important for risk stratification of myelofibrosis. So just briefly, just to recapitulate the cytogenetic risk classification for myelofibrosis, you have a group called very high risk group, which has a lot of chromosomal abnormalities with chromosome 7, 12, etc., etc. So this is one of the cases which showed a monosomy 7. This is what a monosomy 7 looks like. We do this on karyotyping. And then these are the various prognostic models, what they do. So MIPS 70, you have one high molecular risk mutation, and you have two, or you have more than 2 mutations along with type 1 CALR absence. It gives certain number of points, you add the points together, and finally look at the total. So as I said, MIPS take into account clinical variables and genetic variables. And here it takes into account clinical and genetic variables and karyotypes. And this is the GIPS, which takes into account. As you can see, what is most important, you look at all the mutations, which I've talked about. You look at CALR, which we've talked about. You look at high-risk karyotyping, which we need to look. And then we need to look at all these mutations, which includes the mutations that I said, which we find in triple negative ones as well. So with these advances, we know that even though molecular genetics is really not so important in differentiating between the different subtypes, nevertheless, it has a very important role in differentiating the clonal MPNs from non-clonal reactive disorders, which mimic these situations. However, it has certainly a much more important role along with cytogenetics in the risk stratification of primary myelofibrosis that is there. So with this, I would like to thank you very much for a patient hearing. And I think we must somehow try to incorporate molecular and cytogenetic studies into our repertoire so that we keep abreast along with the way the international progression is going. Thank you very much for your patience.
Thank you, ma'am, for a very explicit molecular explanation to MPNs. There are few questions, and some of them are from my side only. And my first question is that we are highly suspecting an MPN, and in our lab it turns out to be triple negative. So what should be the next step? Should we send it for the NGS? How will we, which is the best mode so we get these other mutations?
So is that for me?
Yes, ma'am.
Okay. So you are suspecting MDS?
No, ma'am. We are suspecting MPN, but it
MPN,
turns out,
but you're
all three negative. Yes.
So go in for NGS.
So all the rest of the mutations we can only make out
NGS.
And yes, one more question. In your study, you had CAL mutations. And was there any typical phenotype that you could find with the presence of CAL mutations?
So we didn't find a very typical CALR mutation, but we did find that they had higher WBC, and we did find that their responses when we looked at to therapy were good. That's all that we found.
Thank you, ma'am. Any more questions? Can we have more questions?
Oh, yes.
Yeah, I think there's a question from Dr. Paramjit Dhoot. How to diagnose an acellular or a hypocellular bone marrow?
To diagnose hypocellular or acellular marrow, one has to do a bone marrow trephine biopsy. And then it should be an adequate biopsy so that it is not a subcortical part. Because in adults, subcortical part is about 1 to 1.5 centimeter where there is no marrow. So we must have a biopsy which is at least 2.5 centimeters long to say, yes, there is hypocellular marrow.
Sir, one question from my side. As you said, the final ball, in spite of all the molecular mutation, lies in the court of a pathologist to make the final diagnosis of amongst the three MPNs. One doubt I have is if there is a very high hemoglobin, as in that case you showed us, you had 17 plus hemoglobin, should pre-PMF be one of the differentials still? Because I have this personal doubt that I always feel that if you're going towards PMF, there has to be certain amount of anemia. Or should the pre-PMF still be a differential?
See, actually, these myeloproliferative neoplasms, they change from one to another. They may present with thrombocytosis, but ultimately they may go on to polycythemia vera, or they may present with a high hemoglobin and then they may go on to a primary myelofibrosis. So I think that is why whenever we suspect that it is a myeloproliferative, then we go on to all the three mutations simultaneously in a reflex manner, starting with JAK2 because this being the commonest, followed by CALR, and then followed by MPL mutations, because it is variable. And therefore, till such mutations were not a routine part of investigation, we used to think that this is a case of polycythemia vera, but later on would emerge with a massive spleen and turn out to be, if you do the biopsy, it would turn out to be a case of primary myelofibrosis.
Very right, sir. So that's why in our lab, so we've kept an MPN reflex panel.
Yes.
So we kept it cheap because these tests are mutually exclusive. 80% go into JAK2. So if JAK2 is negative, we do CALR. If CALR is also negative, then we do the MPN. So that's why we have kept it below 10,000 rupees by doing all as a reflex panel. We've also kept an extended MPN reflex where it's BCR able, followed by the MPN reflex in suspected MPNs. And one, we have just kept the extended JAK. So where there's a clear cut, they think it's only polycythemia vera, we do both the mutations of JAK2.
Right. But what is greater need now is that in government institutions, by and large, these molecular things are not carried.
There.
I think
they should be there.
So hopefully it will come because all government hospitals now have gone in for quantitative, the RQ-PCR equipment to do the COVID, though they are not doing quantitative, they're doing qualitative, but they're doing it on the RQ-PCR equipment.
now
And
the
once
same
they
equipment is
the
required.
RQ-PCR equipment, they have learned to use it. I think now they can go in for the
I think they can do it
molecular
now.
workup in hematopathology. So this has, in fact, COVID has been bad for everyone, but it's given a lot of, even the smallest government laboratories, molecular setups. So that is very good. So they can, in fact, go in for that on the same equipments.
Yes, because the diagnostic challenge which occurs in government institution, it will disappear. We will have an exact diagnosis what we are dealing with. Earlier, we just used to say just MPN.
Very right, sir.
Should in the of course the government is different, but should a clinician send for the NGS upfront, or does NGS still have a role if it is JAK2 positive also?
See, I don't think NGS we should take upfront. We should go with, because these driver mutations, 4 of them will clinch diagnosis in 90% of the cases straight away. So NGS,
I think for diagnosis, I think it's the triple negative ones that you would want to go in for.
After they've already been worked out.
Nevertheless, if you have to risk stratify, then you might, I don't know how many clinicians are tailoring the treatment to actual risk stratification classes. But if you go by the latest risk stratification class, there you would have seen that you do have points given for these mutations as well. So even though not to be used upfront, definitely not for upfront diagnosis, but if clinicians are going to manage their patients based on risk stratification, then there may be a point in.
Right.
So there's a question from Dr. Uma Rani for you. Difference between micro and dwarf megakaryocytes.
See, the dwarf megakaryocytes are smaller in size. They are larger than micro megakaryocytes. See, micro megakaryocyte is a feature of MDS, where we find that the nucleus is round and there is a cytoplasm which is slightly more than what we come across in any blast cell. And the nucleus is eccentric. Some of the cells may be binucleated also, as I had shown. So micromegakaryocyte is a feature of MDS. Dwarf megakaryocyte is at least 3 to 6 times the size of a micromegakaryocyte. And these are just smaller megakaryocytes with hypolobated nuclei. That means the nuclei may show 1 or 2 lobulations only. And this is a feature of CML. In CML, we always come across megakaryocytic hyperplasia, especially in later stages where the reticulin fibril also are laid down. So these dwarf megakaryocytes give a clue that we are dealing with a case of CML, in which later stage only. So that is the difference between a micro and a dwarf megakaryocyte.
So should immunohistochemistry for megakaryocyte be put, or will it be helpful in MPNs?
In MPN, not much, except for the fact that the micro megakaryocytes or the megakaryoblast. See, sometimes these cases have accelerated phase and then they go on to blastic phase. If the patient is going on to a megakaryobllastic phase, then we can pick up the blastoid cells that these belong to the megakaryocytic series by carrying out CD61 or by CD117 or CD34 or even PAX5 for lymphoid and CD10 for lymphoid. That is where the role of immunohistochemistry comes, to pick up accelerated phase and blastic phase.
Thank you, sir.
There are some questions on chronic eosinophilic leukemia clonality. I think we can discuss them when we have the talk in the third session on eosinophilia and the mutations associated with that. So we won't take that question. Dr. Sabina, I think we can conclude.
Thank you, sir, Dr. Tejinder Singh, thank you, Dr. Renu Saxena, ma'am, for such elusive explanation of a very, very difficult topic. And we keep dealing with it every day and learning from the stalwarts like you. The next webinar will be a case-based discussion further on Philadelphia negative MPNs. It will be what we have been facing on a day-to-day basis and how we came to the final diagnosis. And thank you all the participants for joining in. And I hope you and all of us have gained a lot today from the webinar. The webinar link for the further webinars will remain the same. So kindly save the link. Thank you. And thank you, Dr. Jyoti, for making such a wonderful program.
Thank you very much. And hope to see you soon after 2 weeks.
Yeah.
Thank you, sir. Thank you, ma'am.
Thank you.
Thanks.